Good afternoon, everyone, and welcome to today's PHO Rounds presentation on leveraging momentum, building outreach capacity, and point-of-care syphilis rapid testing and treatment practices. My name is Jennifer Burbage. I'm a nurse consultant at Public Health Ontario, and I have the pleasure of moderating today's session. Before we begin, I'd like to take a moment to acknowledge the land on which we are hosting today's session. My ancestors are settlers from Europe, and I want to acknowledge the colonial history of Canada and the continued struggles faced by Indigenous peoples. Many of you are joining us from all over Turtle Island, but I acknowledge that the land we are hosting this virtual education session on is on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. I acknowledge that this territory is governed by Treaty 13, also known as the Toronto Purchase. Today, this place is still the home to many First Nations, Inuit, and Métis peoples from across Turtle Island, and I'm grateful to have the opportunity to gather and work on this land. Before we begin the presentation, I'll just cover a few housekeeping items. I'd like to start by disclosing that I have no conflicts of interest to declare. And lastly, a reminder to everyone to save the date for TOPIC, the Ontario Public Health Convention, which will be held on March 26th and April 2nd, 2025. Registration for this event has opened, so check out www.tophc.ca for details. It is now my pleasure to introduce the speakers for today's presentation, Candice Belanger, Stephanie Vance, and Lucy McCrell. Candice oversees the street outreach and harm reduction programs at the Thunder Bay District Health Unit, bringing extensive experience in addictions and mental health. She is deeply committed to supporting communities disproportionately affected by health and social inequities. Candice holds a Bachelor of Science in Nursing from Lakehead University and a Master of Health Management from McMaster University. In addition to her professional role, she contributes to her community as a director on the board of the United Way of Thunder Bay. Stephanie is a registered nurse with over 10 years of experience in public health at Southeast Health Unit, formerly Hastings Prince Edward Public Health. She plays a key role in the sexual health and harm reduction program, leading program planning, coordinating outreach efforts, and managing the implementation of point-of-care testing initiatives. Stephanie's dedication to improving community health is grounded in her academic foundation, having earned a Bachelor of Science in Nursing from Laurentian University. Lucy is a PhD candidate in public health, specializing in epidemiology at Queen's University. Her research focuses on improving healthcare accessibility for populations that face systemic barriers. She holds a Bachelor of Arts with Honors and a Master of Arts in Global Development Studies from Queen's University, as well as a Master of Social Work from McGill University. From 2018 to 2023, Lucy worked as a clinical social worker focusing on psychotherapy, crisis intervention, and mental health risk assessments in emergency departments at Kingston General Hospital. I'll now pass it over to Candice to get the presentation started.
Thank you, Jennifer. Good afternoon, and thank you for joining today. We are very excited to share some of our work with you. So just as a disclaimer, this presentation was created by us and an external organization, and while it's going to be published by Public Health Ontario, PHO is not the owner of the content, and there's no liability resulting from application or use. We have no disclosures to declare, and the objectives for this presentation are that by the end of this session, you'll be able to describe the elements of a flexible nursing outreach with point-of-care testing for syphilis HIV, including identifying and overcoming barriers to implementation and improving processes. Explain the ways in which capacity can be built across the province to implement and evaluate point-of-care testing for syphilis HIV, including leveraging current and future evaluation findings. And describe how actors in local public health units can foster intersectoral collaboration around syphilis diagnosis and treatment, including POCT and outreach nursing models. We would like to acknowledge that this work was supported by the Locally Driven Collaborative Projects grant from 2023 to 24, and from Public Health Ontario and the Canadian Institutes of Health Research, CIHR, through the 2023 Catalyst grant. And these are the partners that were involved in the work. So we felt that one of the best ways to leverage our learnings and meet the objectives of our presentation was to take you back a few steps and to take you through why we undertook this work, how we did the work, what happened or what our results were, and sort of what the next steps are, or the so what. So why we undertook this work. So we have seen in a lot of different areas a significant spike in infectious syphilis. So for those of you in the room that may not be familiar, syphilis is a sexually transmitted infection, often asymptomatic or having vague symptoms, used to be referred to as the great imitator at one point. So it can look like different things and be a bit confusing to diagnose. But left untreated can cause some significant health complications and can be very serious. So the incidence of infectious syphilis has increased dramatically. And in this situation, we were talking about the Kingston, Frontenac, Leeds, and Addington, Lennox and Addington, health unit, now known as Southeast Health Unit, but I'm probably going to refer to them as KFLA throughout because that's what I am used to. There was an increase in 672% from 2019 to 2023 in syphilis, And they had the highest rate, third highest rate in the province, which is now more than double the provincial rate. And so early on, KFLA saw infections most often in men, and specifically men who have sex with men, but then more and more were becoming infected. This subsequently led to, more and more women were becoming infected, and this subsequently led to congenital cases or babies born to persons who have been infected with syphilis. And there was a total of 6 congenital cases in 2022, 2023, which is significant. And here in Thunder Bay, we were experiencing a very similar significant spike. And we actually have the second highest provincial rate of infectious syphilis here in Thunder Bay. Hastings, Prince Edward Public Health, and Leeds, Grenville, Lanark, the rates are a bit lower, but they have been rising as well, or seeing a similar increase. And so because of these numbers, KFLA Public Health declared a syphilis outbreak in late 2022 and mobilized a community syphilis committee to oversee the public health response. And while TBDHU has not declared an outbreak, we have been exploring all possible public health interventions to address our concerning increase as well. And so what this looks like in practice, I can say, in my 16 years of public health experience, when I first began as a public health nurse in sexual health, we would see perhaps 3 to 4 cases of infectious syphilis in 1 year. And now we are dealing in Thunder Bay with at least 3 to 4 cases in our clinic per week. So a very significant increase. So while the sheer number of cases is concerning, or the increase in the rates is super concerning, additional concerns were the shift in the risk factors among individuals who are acquiring syphilis. And particularly, as noted in the previous slide, that more women were being impacted by syphilis, and particularly women of childbearing age. There are a lot of social and structural determinants of health and health inequities that really do play a role in increasing the risk factors for syphilis for individuals. So people who are unhoused or underhoused, people who are involved, street involved, who are using illicit substances, and who may be practicing sex work or survival sex. Many of these so this leads to sort of a shift in the individuals who were seeing most impacted by syphilis. A third piece that was of concern, or why we undertook the work, was to help decrease time to treatment. So early and effective treatment is important to avoid complications with syphilis. KFLA found that their own data that the time to treatment for new infections or reinfections across all providers in their district was 10 days, which included weekend days. 10 days is quite a long time, but public health nurses have commented that a lot of the outliers that you see in this graph that's on your slide relate to folks who have social or economic challenges, who maybe don't have a fixed address or a reliable way to contact them. So that does increase the time to treatment, and it's more challenging. So that was the why, and this is the how. Oh, sorry about that. So through the implementation of a point of care test for syphilis, which is a tool that we can use, we were able to leverage a few different pieces. So we were able to address some of those social and the equity pieces in terms of ensuring that those who should be tested or who would have the greatest benefit from testing are getting tested. And so we wanted to implement a really low barrier testing for syphilis. And so point of care testing, which is essentially a rapid test that we can do in the moment, helps to identify and potentially shorten that interval to treatment. And we really, by leveraging an outreach model, so some of the different health units involved had an outreach system in place, which would bring public health services like testing to individuals at greatest risk. So we leverage this test in those populations to enhance testing and ensure access to testing. In order to do that, we implemented the INSTI Multiplex for HIV and syphilis, which is the only point of care test approved, or it was the only point of care test approved at that time for use in Canada. That has since changed. And we wanted to integrate it with current outreach models and prevention efforts. And so in order for that to be effective, we also needed a medical directive in place so that nurses could initiate treatment when syphilis was identified with the point of care test. And then we would also conduct confirmatory serology, which allowed us to also evaluate the way in which the test was working. And so this is what the multiplex HIV and syphilis antibody test looks like. And so it's a finger poke or a capillary fill of blood, so not a very large amount. And then it's mixed with a diluent followed by a color developer and then a clarifying solution. The results are read after 1 minute. And then if it sits around too long, they are no longer valid after 5 minutes. And if a reactive syphilis antibody is detected, it's considered a new or a reinfection. And and then we would treat based on our medical directive. And so the medical directives varied slightly from health unit to health unit, but essentially were to achieve the same goal of reducing time to treatment. And so our research goals were really to build capacity to implement and evaluate a flexible outreach model with the syphilis HIV INSTI point of care test within the 5 health units that were initially participating. We really targeted those who were underhoused, people who were using substances, those who were street involved, really those who faced some of the biggest barriers to care and to testing. So we were part of a locally driven collaborative program funded in August, which I mentioned earlier. Collaboration, data collection, and knowledge translation has continued until September 2024 and continues to this day. Our ethics was approved through the Queen's University REB. So the design of our research followed the RE-AIM framework. Our objectives were to develop a community of practice, and this was really essential in meeting all of our other objectives. It provided an opportunity to talk about our our challenges, our goals, and really sort of set the tone and support each other. Other objectives include monitoring the program process metrics, assessing performance of the POCT or the point of care test in the real world setting. So often when we're doing testing events or testing in the community, those environments are not always, a clinical environment. And so we really wanted to understand how this test performed in those real world settings. We wanted to understand factors related to the delivery and utility of the test from a clinical and population health perspective. So we used mixed methods. There was a preliminary implementation evaluation, clinical data, survey of healthcare provider implementers, and documentation. And we used a quantitative and qualitative analysis. And so now I'm going to turn it over to Stephanie Vance, who's going to discuss the project implementation more in depth.
Thanks, Candace. So to tell you what happened, I guess I'll first review our timeline for implementation for the entirety of our LDCP cycle. So it began briefly in the spring of 2023. KFL&A Public Health had developed their policies and procedures and medical directives to be able to implement the INSTI Multiplex point of care test through their outreach programs. And just reflecting on the outbreak that they declared earlier in the 2022 that Candace mentioned, KFL&A had applied for a special access grant under Health Canada Special Access Program to be able to implement point of care ahead of INSTI having Health Canada approval. So that's why they had some of that groundwork already underway. In March of 23, that's when INSTI did receive Health Canada approval, and it was around that same time when all 5 participating public health units did come together and apply for funding for the locally driven collaborative project. We were, of course, led by KFL&A in that application. So shortly after, in June of 23, KFL&A did begin their implementation, and all their data collection in that portion of the pre-LDCP funding stage was included in the project as well. In August of 23, we did receive funding from PHO, and it was at that time that the 5 participating public health units began collaborating through our community of practice. The community of practice is really essential in capacity building for all 5 public health units, as this is where we shared resources with each other, built on lessons learned, reported back on our own internal policy procedure, medical directive development and approval processes. And it's also where we provided input and feedback on point of care test evaluation processes. The policy procedure, medical directive, training of staff, quality assurance processes, all of that took several months for most health units. And so it was by November of 23 and January of 2024 when Hastings, Leeds, and Thunder Bay were in a position to begin implementing point of care testing in their own respective outreach programs. Ottawa Public Health unfortunately had a delayed implementation related to capacity issues. This was a barrier that many of our health units experienced throughout the project at one point or another, related to staffing or other competing public health priorities. But nevertheless, implementation did begin in March for Ottawa, and it was around that time as well that we submitted our midterm monitoring report, to PHO. Outreach continued beyond then, and it was at the end of August of 2024 when data was pulled and analysis began for our final report, which was eventually submitted in October of 2024. Just as Candace had mentioned previously, our community practice and our outreach efforts, including point of care, have continued beyond this LDCP cycle. So in terms of the participating health units, at the beginning of the LDCP, they were all at various stages of involvement with an outreach program prior to the project. Several public health units incorporated point-of-care test and treat model into their pre-existing harm reduction sexual health outreach programs, while one PHU had to reestablish an outreach program and another revamped an existing outreach program. The outreach programs are very unique to the community context and capacity of each respective PHU, and the activities organized through outreach really differed across the region. You know, we all know working in public health that unique communities really require unique approaches that are tailored to the needs of that specific community. And the flexible outreach model is really something that complements that approach, and what we found being successful in this project. During the study period, there were 164 total different implemented activities that occurred, and these were blitzes or pop-up testing events that occurred at partner locations. Some of these events were advertised, while others we relied on word of mouth from clients and other community partners to get participation. Most of the outreach initiatives utilized only 1 to 2 nurses per activity, while larger scale activities like an event or a blitz would require more staff and sometimes utilized up to 6. Staff varied in terms of who was used. There was anywhere from nurses, nurse practitioners, outreach workers, data clerks, social workers, whatever that organization needed to make a testing event successful. Majority of point of care test activities did take place indoors. The cold really is a barrier for point of care testing, unfortunately, because of the temp sensitivity of the test, but also just like with outreach in general, it's a lot harder to locate clients in the colder months. And so because a fair amount of months of our project did take place over the colder time period, the activities were more successful indoors for a majority of the time. One public health unit did have a mobile outreach van that was already a part of their outreach program, and they were able to offer point of care testing through that van with success. And I should mention that all point of care testing was incentivized. So clients were offered an incentivized gift card or cash in some instances to participate in point of care. And one public health unit also was able to incentivize the paired serology portion of testing, which of course you could imagine did increase the uptake. Again, the goal of the flexible outreach model of care is really to engage clients outside of that traditional clinic setting so that we can reduce barriers to screening and treatment and reach people who otherwise would not be getting engaged in care. As you can see by this figure here, which really reflects the differing approaches to outreach models among the 5 participating public health units, and how we each applied a different activity to get point of care test participation. So in some locations, this made sense to do larger testing events where they might have food available for participants, do draws for prizes for those who were waiting, but also at general outreach, visiting encampments, or OAT clinics with partners in the community. And sometimes it meant just engaging clients through our harm reduction programs when they presented for supplies. So by August of 2024, the end of the LDCP cycle, there were a total of 552 valid point of care test results from 512 unique individuals. And 567 were attempted in total, and that's across all 5 public health unit regions. Again, that's 512 individuals who perhaps may not have been engaged in screening without implementing this flexible outreach model and point of care. Majority of point of care tests are completed by KSLNA Public Health, which also reflects their 6-month lead on implementing point of care tests. Thunder Bay followed next, and then Hastings and Leeds and Ottawa Public Health. Age range for participants was between 16 and 72 years, with a mean age of 39.9 years for participants. And of the total tests that were completed, a really sizable proportion were those in individuals identifying as female, and nearly a quarter reported not yet being connected to any community services. So just really highlights that we were targeting or we were connecting with the people we were wanting to target. Most of 4% of our participants did not have 4% of our participants did have symptoms consistent with syphilis. So this isn't surprising that there weren't more because, as we've mentioned, one, the symptoms can be quite difficult to discern from other ailments. Clients don't always associate their symptoms with syphilis, even when you're offering them specific things. But also there's a large timelines of the infection where the individual is asymptomatic altogether. Most were tested at the larger scale testing events or blitzes at community service hubs. And I think that really highlights the importance of using partnerships when developing a flexible outreach model of care. As part of our intake process, participants were asked to report their risk factors, and the largest indicator reported by participants was housing instability, with 66% reporting instability, reporting being underhoused or experiencing homelessness. And nearly a third reported having used intravenous drugs, and nearly a quarter reported having multiple sex partners in the previous 6 months. So this slide is highlighting results from those of our participants who did report a valid postal code. So 47.1% of our participants did not report a postal code of residence, and 2.5% didn't know their postal code. So for the remainder who did have a postal code that was reported and that we could link to material and social deprivation index scores, this is the result of that. So material deprivation measures socioeconomic status, and social deprivation captures social isolation. A lower score indicates less deprivation, whereas a higher score indicates more deprivation. So as you can see, of those who did provide a valid postal code to us through participation, they were linked to the highest quintiles of material and social deprivation. You note the dotted line at 20%. That just indicates that should there have been no inequities, there would be equal representation among all 5 quintiles. And so theoretically, the bars would all be at that 20% mark. Again, just kind of highlighting the fact that we did reach a sizable proportion of our target population.
So I'm going to talk a little bit about the research results that we found. So first of all, of the overall point of care tests, so Stephanie mentioned that 567 point of care tests were attempted, of which 97.4% were valid, and then 87.8% consented to standard laboratory serology testing for a total of 498. And so as you can see on this table here, the overall reactive rate for the syphilis point of care test was 5.6%. And then for the syphilis serology, it was 7.6%. For the HIV point of care test, the reactive rate was 2.2%, and then HIV serology was 1.6%. So I'm going to talk a little bit about the diagnostic accuracy tests. So in total, there were 479 paired tests. And so those are the ones that were included in the analysis. And when I say paired tests, that means that they had a valid point of care test result and a serology result. So for syphilis overall, the syphilis seroprevalence was 6.1%. Oh, sorry, the point of care percent positivity was 6.1. The syphilis serology was 7.7. And so we have here a sensitivity of 70.3%, very high specificity of 99.3%, and then positive predictive value 89.7, and negative predictive value of 97.6. So as we know, sensitivity and specificity are pretty stable regardless of prevalence in the population. But for PPV and NPV, it does depend on the prevalence rates in the population, which is slightly difficult to really interpret in this context, considering there were different regions that have different prevalence rates. And this is part of the reason that we are hoping to, in the future, stratify by public health unit to really understand the different PPV and NPV based on the region. So overall, there were 26 true positives that were found using the point of care test. So 15 or 58% of these were new or reinfections, and of those 15, 12 were treated at the point of care. So the two of the three that were not treated were reinfections where clients reported being recently treated elsewhere. And then for the third, the person did not want to be treated due to a lack of privacy. They did, however, consent to notifying their primary care provider of the results and the need for treatment, and so that connection was made there. And so of the 13, 50%, of the 13, 50% had RPR dilutions of greater than 1 to 8. So of the 11 false negatives, the majority, so 73%, were previously treated infections. And then all of the false negatives had RPR dilutions of either less than 1 to 2 or were non-reactive. So for those that were new reinfections, this speaks to possibly very early or late infection. And so of the 3 false positives, all 3 were treated at point of care. And then following the receipt of the results telling us that these were false positives, 2 of the 3 clients were notified and counseled about the unnecessary treatment. However, 1 client was not locatable. So I'm going to talk a little bit about the healthcare provider implementer survey. So this survey was sent out to individuals who were frontline offering the test, so mostly public health nurses, and it contained a series of questions asking about either the level to which you agree with a statement or the level of difficulty associated with specific tasks. And so from those series of questions, we came with a subdomain score for willingness, suitability, satisfaction, and learnability. We also did have open text boxes, which I will go into a little bit in the next slide. But so overall, you can see there's high scores on all of those subdomains. So willingness was defined as the provider's intention to carry out the point of care test, wait for results, treat, and refer as necessary. Suitability is the belief that the test is relevant for the provider's work and that it could be successfully integrated into existing services. Satisfaction is the feeling that completing the test is both convenient and enjoyable. And then for learnability, it was the ability of the providers to understand how to perform the point of care test and accurately read the results. Of note with learnability as well, the median number of trainings for the point of care test that survey participants needed before they felt comfortable performing the point of care test was 1, which is quite low. So there were some concerns noted that were mostly in the open text boxes. And so in terms of test accuracy, 31% of participants indicated concern over the performance of the results. So in particular, there was concern for clients with low RPR who may have syphilis either in incubating or late latent stages. 2 other participants were also concerned with the possibility of false positives. So one due to the fact that they had a false positive test, and another, there was confusion around the product instructions, that there was some misinterpretation around there potentially being other non-syphilis infections that may cause false positive results. Of note, there wasn't a belief that it reduced the workload of outreach nurses. So we had 5 respondents starting the point of care test actually takes longer than usual serology as an additional step, and that also following up with confirmatory serology poses a challenge due to the transient nature of many of the folks that were involved. Test functionality was also commented on, so 35% commented on the challenges that the pipette specifically posed, and then 15% commented on the difficulty of collecting an adequate amount of blood due to the lancet providing in the kits, with 2 participants noting that it can result in often needing to perform multiple finger pricks, which obviously is not ideal. Outreach conditions were another concern noted. So, for example, although 76% of tests were offered indoors, 25% were offered outdoors. And so things like even just the lightweight nature of the tests posed concerns around the windy conditions. Also, kits require temperature stable between 15 and 30 degrees. And so for outreach conditions, this can pose a challenge. However, despite these concerns, 100% of respondents indicated that they're willing to consistently offer and perform the model of care, and then 100% also agreed that it should continue to be offered through outreach services. One thing that was also really interesting and noted in the survey was that participants commended the intervention on its ability to get immediate treatment to clients, but also the opportunity offered to connect with clients. So as you can see in this quote here, it allowed nurses to have conversations around other STD-BI testing, or for folks who'd previously been treated, the importance of follow-up serology. So now I'm going to talk a bit about the so what. So sort of reiterating what we've already talked about, but I'm going to just hit home on some things. So as I talked about before, it's obvious that this model of care reached the target population, with the large proportion of clients being unhoused or underhoused, not having a residential address, using injection drug use, illicit drug use, and multiple sexual partners. Something that was noted throughout both community of practice and also in these results is the difficulty of picking up low RPR titers. And so, as we said, clients with low RPR have accounted for all false negatives thus far. And because INSTI is meant to detect both IgG and IgM antibodies, it doesn't distinguish between new or previous infections. And so I should mention this before, but the consequences of not detecting individuals who have low RPR is that it has consequences for identifying folks either in early stages of infection or latent infections. And so overall, really, we need more data. because currently these results are underpowered, so interpret them with caution. That being said, as was mentioned, we are continuing to collect data with the ultimate goal of having around 1,000 tests that are paired between point of care and serology. And this will hopefully also allow us to disaggregate by public health unit to remove the potential effect of regional variations. So, as I just mentioned, here's some key takeaways, but we are obviously most interested in identifying and treating new or reinfections. But as with serology, the point of care test is unable to distinguish between the two. And so this really underlines the importance of clinical assessment and judgment, which is made more difficult in the field. So for example, difficulty doing contact tracing or doing symptom assessment during outreach conditions. And so because of this, we think that the test may be most useful at the beginning of an outbreak or in a population with low prevalence of syphilis, due to the low RPR. That being said, it does appear to be useful in interrupting the chain of transmission. I'll talk about it in a little bit, but there has been a research project that used network models that actually looked at the potential impact of this model of care in interrupting ongoing transmission. Another key takeaway for us is that it has really allowed meaningful engagement with underserved populations. So it has enabled discussion, like I was saying, with clients who previously were treated around the need to follow serology. It's allowed more engagement with respect to STBBI testing overall. And it's also facilitated building relationships with community and individuals from the public health units. So this is a diagram of all the different public health units and community-based organizations that were involved in this project. And so as you can see, there are a lot of different connections. And I think another really large takeaway for all of us is the importance of maintaining partnerships and building trust. So both between public health units, but between public health units and community-based organizations and with the populations themselves. So I'm going to talk a little bit about the different partnerships we have and the different spin-off projects and continuing research that's being done. So we have extended to 3 northern, more rural public health units with funding provided through the Community Institutes of Health Research. So these public health units are Renfrew, Algoma, and Porcupine, or now Northeastern Public Health. The other ongoing projects, we're looking at evaluating the longer-term effectiveness of the model of care, looking at the differences in lost follow-up, median time to treatment, test positivity rates. And I already talked about the network model that we're using. We're also looking to understand the perspectives of the population on both this model of care and syphilis testing more broadly. This will be done through qualitative interviews starting this month, as well as a discrete choice experiment, which is a larger survey, which will be conducted in 2026. We are also looking to understand the perspectives of decision makers. So for this, we're using a qualitative case study methodology, starting with KFLNA, but we're expanding to more public health units, hopefully very soon. We're also fortunate that we've received another LDCP funding through PHO that will be looking at specifically building and evaluating knowledge mobilization networks. So that brings us to the end of our presentation, but thank you so much for your time, Public Health Ontario, for having us. If you do have any follow-up questions after today, or if you're interested in getting involved, you're welcome to contact the clinical nursing facilitator attached to this project, Mary Southall. Her email is there. So at this point, I'm going to pass back to Jennifer for the Q&A.
Thank you so much, Candace, Stephanie, and Lucy, for that excellent presentation. It's really just such a joy and a privilege to hear your experiences and successes implementing this approach to really reach those who are facing barriers to care. So thank you so much. And now we have some time for some questions, so we'll move into the Q&A segment to answer questions from our audience. So for first question, I think we can go with a clarification on, for the outreach model of care, when you were referring to offering clinical services, was this offered by public health, or did you collaborate with any agencies or within the healthcare system?
I think I can answer just to what I know. The model is so different amongst each different health unit, and we honestly did so many different things as a team. But when I'm speaking to clinical services, I do mean those delivered by public health. We definitely worked in partnership with other clinical service organizations in terms of like locating clients and communicating about what services we were there to offer, and what we could do as a team to get the best care for the individual. But in terms of the test and treat model in clinical service, it was public health.
Great. Another question was the requirement for concurrent serology at time of test, a barrier or a challenge to this program?
I can take this one. Oh,
Sure.
No, I was gonna take it because I think we perceived it. So in Thunder Bay, we perceived it as a potential barrier. And so we were the public health unit that incentivized both the point of care test and the serology, which did definitely help ensure that we got both of those completed.
I might just add, from the survey as well, there were some comments around difficulty collecting serology with this population due to having to do blood draws in the field with folks who maybe had collapsed veins. So there was that comment as well, but
that's what I was going to add. Also, in terms of the serology being a barrier from like the client's perspective, when we're presenting point of care and the need to do a follow-up blood draw, confirm what results we're seeing, I'd say that wasn't a huge barrier in terms of their acceptance of the care that we were offering them, but it was more of a barrier in terms of the nurse being able to achieve what we wanted to achieve because of the things that Lucy mentioned, at least in our region.
Wonderful, thank you. There are quite a few questions coming in around, I guess, what happens after someone tests positive, particularly around staging and follow-up for those who end up being staged as a late latent infection. Can you elaborate a bit on either the directives that were in place for staging the clients and maybe following up on those who needed additional testing or treatment, sorry?
Again, I can answer to our process because, like we said in the presentation, each PHU had their own medical directives. There may have been similarities, but again, lots of differences in the way things are structured and organized. So for us at Southeast, but formerly Hastings, Prince Edward Public Health, we do the assessment point of care. If point of care was reactive, we would initiate their treatment, and staging takes place after the fact. So if the person had significant symptoms through our assessment that came through, then we would create a plan with the client and other community partners that might be involved with that client for us to be able to follow up with them after the fact so that we can update their care plan. If we truly believed it was a primary case of syphilis based on their symptomology, then we would still create that plan of care, but not as much urgency to want to reconnect with them as soon as possible. But essentially, we do the treatment. The goal is just to initiate their treatment and get that into them as soon as possible. And then we do case consult with our MOH after the fact, review the assessment, what was done, what the plan is for follow-up, and then he would stage based on the assessment that came forward, and we would go from there.
And it was very similar for us in Thunder Bay. So we would also do the testing based on the positive test. We note the symptomology, have an idea, based on symptoms and other things where they might fit. However, it would go on to we are lucky enough to have a nurse practitioner attached to our outreach program, actually two, part-time ones. And so they would assess the serology results and make recommendations for the continued treatment, or whether that was a primary or secondary or otherwise.
Great. We have a question around the acceptability or the perception of this program among Indigenous people specifically in Thunder Bay. Did you want to comment on that, Candace?
Apologies, could you repeat the question?
Sure. It was a question of what's the acceptability or perception on this program for Indigenous population in Thunder Bay, or was this evaluated or looked at during the implementation?
We didn't specifically evaluate the acceptance amongst people who are Indigenous. We do know that our street outreach program does serve a lot of individuals who identify as Indigenous, and I don't think that we saw any difference in uptake between clients. It was generally very well accepted. We do have a fairly well-established outreach program here. Our street outreach program has been in existence for some time, and so we have really good rapport and relationships with our clients.
Great. And question is, this may be our last question, is if you have any advice for health units who would like to undertake point-of-care syphilis testing with similar populations, for anyone on the panel.
I think one of the considerations would be, and this was highlighted in our presentation, was where your community sits in terms of rates of syphilis, because it is most usefulness in terms of identifying new infections, this particular test. So I think thinking about those pieces would be important, and having the pieces in place, like we talked about with the directives, and how follow-up is going to occur in terms of confirming and following up with treatment.
Any other advice? No.
I could add to just in terms of wanting to implement it and wanting good success. Sometimes like our traditional view of outreach is going out like on your own to find people. And I think that the most success in outreach comes from partnerships in the community with other agencies. So I think building upon partnerships simultaneously while trying to build your own capacity to develop policy and procedure directives and all that for point of care would make the implementation phase probably a lot more successful.
Wonderful. Thank you.
And if anybody wants more, the email at the end on the last slide, Mary Sothall, is the person to reach out.
Great. All right. So as we wrap up today's session, I would just like to thank again Candace Belanger, Stephanie Vance, and Lucy McCrell for presenting. And I would like to thank everyone who joined us for today's event. And thank you all, and have a wonderful day.